Hello, how are you all? Hope you all are fine and preparing well for your AMC Part 1 examination. This is Dr. Zara and we are doing some important sentences, some important lines which can come in SBA from John Murtagh book, the most important book for AMC Part 1 examination. So today we will discuss and we will finish this chapter. Let's do the quick recap from the previous discussion. Believe me, if you are following all my discussion and listening all my discussion carefully, um, you will be able to solve your AMC Part 1 SBA Gynae Ops section. 90% you will be able to solve all the single best answer if you are following and listening this discussion, because side by side I am also doing the quick revision. So let's do the quick recap. We discussed this that is cervical cancer is the fourth most common cause of cancer death in the women. The most common cervical cancer is squamous cell. The most common risk factor is HPV, human papilloma virus, who have been sexually active. Other risk factors, sometimes they are asking in the SB, is smoking, use of combined oral contraceptive pills greater than 5 years increase the risk of cervical cancer, immunosuppression, and exposure to diethylstilbestrol. Okay, all right. And 16 in 18 HPV 16 and 18, human papilloma virus 16 and 18 are responsible for around 70% of invasive cervical cancer and 50% of high grade lesion. Basic pathology, we all know that squamous cell carcinoma always arises in the transformation zone. We already discussed. This is the to clear the concept of the transformation zone. Mild dysplasia, we are labeling sin grade as sin 1, and in Australian modified Bethesda system, it is low grade. Then moderate onward, it is high grade. Till invasive, invasive become invasive. Okay. Most common clinical presentation is irregular vaginal bleeding, postcoital intermenstrual bleeding, postmenopausal bleeding, vaginal discharge, back pain, fatigue, and vaginal fistula. So the cervical screening program now changed from the 2 yearly to a 5 yearly cervical screening test, and they are using a primary HPV test for the cervical screening. Who should be screened? Women are invited to commence cervical screening at 25 years or 2 years after first sexual intercourse, whichever is later. Both HPV vaccinated and non-vaccinated women should be screened. An exit test should be performed at age 70 to 74 years. This should be clear. This statement that exit test, if the last HPV screening test has been performed at age 70 years, then she is no longer there is no longer recommendation for further screening testing. uh, if she is requested, then only. Otherwise, at the age of the 70 years, her screening test will be the last test for the screening purpose, because they are doing screening after every 5 years. So screening is or the exit test is usually from 70 to 74 years. So 70, if it is she has undergone for the screening test, then she is no longer required for the screening cervical screening testing. All right. And women age 75 year or older may request screening. Screening applies only to asymptomatic women. Women with postcoital or persistent intermenstrual bleeding requires a co-test. This can come in SBA. Both HPV and liquid-based cytology, both is required for those women who having a postcoital or persistent intermenstrual bleeding. Okay, and then referral for an appropriate investigation to exclude malignancy should be considered. This is very important point. Please note this point. For women who experience first sexual activity at young age less than 14 years and who do not receive the HPV vaccine before sexual intercourse, a single HPV test between 20 and 24 years of age could be considered on an individual basis. Alright, then screening in a particular group. So hysterectomy for the those women who have undergone for the hysterectomy, then vaginal wall co-test is required. HPV and liquid-based cytology both is required, especially and in those women who have undergone for a hysterectomy with a history of gynecological dysplasia or malignancy. Then for the pregnancy, cervical screening can be safely performed at any time during pregnancy. Postmenopausal women, those women should may benefit from a short course of topical vaginal estrogen, but this should stop approximately 3 days before the test to ensure it does not interfere with the test interpretation. Immune deficient women, HIV, or those women who undergone for a organ transplantation should have the usual screening is every 5 years, but those women who are suffering from HIV or who are undergone for a solid organ transplant recipient, then those women should be screened for every 3 years with HPV testing. Please note this point. Then exposure to diethyl stilbestrol in utero, those women require an annual core test, and colposcopic examination should be offered indefinitely. Women with abnormal vaginal bleeding, this is very important paragraph. Women with abnormal vaginal bleeding, core test is required. Core test means HPV and liquid based cytology is indicated if they are mentioning in the question that women who have a postcoital or intermenstrual bleeding especially. Then those women also refer for colposcopy regardless of the results. So those women who have a postcoital or persistent or unexplained intermenstrual bleeding, then in those women core test is indicated, as well as they should be referred for colposcopy. All right. Then another important point, the most important point frequently coming in the SBA is with women with a postmenopausal bleeding. So women who are postmenopausal and who have a bleeding, vaginal bleeding, always need a further investigation and referral for a specialist gynecological assessment to exclude genital tract malignancy, even if it is looks like that it is all normal, but a woman with a postmenopausal bleeding, always further investigation is required, and referral for a specialist gynecological assessment is always required to rule out the genital tract malignancy. Now for the screening purpose, these are the brush. You can see in the picture A, this is the broom. This B, in B, that is endocervical brush. In the C picture, you can see that they are saving this sampling and further transfer to the laboratory in the liquid based medium, and then this is for the transfer of the laboratory. They are closing and they will transfer to the laboratory. Now for the today we will discuss the management of the results. So what if the cytology is negative, if it's HPV is detected in the sample, so how will be the further investigation and management in those patients? So accordingly we will do. So for suppose they have done the cervical screening test and it's showing HPV not detected. So if HPV is not detected in the cervical screening, further investigation as per routine screening. What's the routine screening? Routine screening is to repeat the cervical screening every 5 years. So HPV, if it is not detected in the first line, you can see, then we have to repeat in every 5 years as per routine screening test. For example, cervical screening test results sent to the laboratory and is showing that HPV test unsatisfactory. So if unsatisfactory results are there, then we have to repeat test in 6 to 12 weeks. All right. So in those patients in which unsatisfactory HPV test results are, we have to repeat test in at least in 3 months. So repeat test in 6 to 12 weeks. So this is important if it is showing unsatisfactory HPV test. Now what if it's showing HPV but not 16 and 18? So remember 16 and 18, these are the high risk HPV. So if the results are showing HPV test is positive, but it is showing that it 16 and 18, these are the high risk HPV. It's not detected, but HPV detected, other HPV viruses detected in the screening results. So we already discussed in the previous discussion In those patients in which HPV is positive, we have to go for the liquid based cytology, in which we will receive the results for the cytology, cell cytology. So then co-test is required if HPV is detected. Okay, so HPV is detected and they did the cytology and it's also showing negative. Okay, in those women in which HPV is detected but not 16 and 18 but negative cytology. All right, so we have to repeat HPV test in 12 month or in 1 year. Okay, 12 month or 1 year. In those patients in which HPV detected and the cytology is showing low grade intraepithelial lesion. All right, so possible low grade or definite low grade. So any one of the results with the cytology, cell liquid based cytology, if we are sending, because HPV already detected and we are sending the liquid based cytology and it is showing the low grade or possible or definite low grade intraepithelial lesion. So in those women we have to repeat HPV test in 12 month again in those women who have a low grade. What if it is showing the cytology is showing high grade intraepithelial lesion, HPV detected but not 16 and 18, but cytology is showing high grade epithelial lesion? So in those women we have to refer for colposcopy for further investigation and further management if it is showing high grade epithelial lesion in cytology. What if cytology is unsatisfactory? Okay, if cytology is unsatisfactory, then we have to repeat the test in 6 to 12 weeks. We have to repeat test in 3 months at least. Within 3 months we have to repeat if it is cytology is showing the unsatisfactory results. Okay, what if HPV detected and 16 and 18 is detected? So we all know this is the very high risk factor for cervical cancer. So with any cytology results, even if it is unsatisfactory, even if it is negative, even if it is any cytology result, all cytology results, even if it is negative cytology result, if HPV 16 and 18 is detected in the cervical screening test, all those women should be referred for colposcopy. This is very important point for SBA. So all cytology result, even if cytology cell liquid based cytology cells results are showing negative, but screening is showing HPV positive for 16 and 18, we have to have refer those patients for colposcopy for further investigation. This is very important point. Now here they have mentioned the test of cure. So what is test of cure? So women who diagnosed with high grade intraepithelial lesion, and we have referred those patients for colposcopy, and the management done for the SIN 2 or SIN 3, because we are it could be a SIN 2 cervical intraepithelial neoplasia type 2 or type 3, and she is treatment done for the high-grade squamous intraepithelial lesion. Then the test of cure. So when to repeat the follow-up test to see that she is free from the high-grade intraepithelial lesion. So follow-up test for those patients who undergone for the treatment. So test of cure, we are labeling that test, and in those patients a co-test is required, HPV and liquid-based cytology both, perform 12 months after treatment. So 12 months after treatment and annually thereafter. So we have to perform after 1 year, and then every year until we receive a on two consecutive occasion we receive a negative co-test. So both HPV and liquid based cytology, once we receive the results, two results which are negative, so that's mean if we are doing it yearly, then after 1 year if we are getting the test negative, then we have to repeat again after 1 year, and if it is again if it is negative, then we have to return for those patients for a normal 5 yearly screening program. Again she will undergo for the routine screening until she have a negative co-test on 2 occasions. All right. So this line is very very important. We already discussed several times. Please don't forget this line. And they have mentioned again also in this page. If HPV 16 or 18 is detected, please remember this point. If HPV 16 or 18 is detected, the patient should be referred directly for cervical colposcopy. So these are the high risk HPV 16 or 18. So these the patient should be referred directly for for a colposcopy, and cervical sample for liquid based cytology will be collected at that visit, and further follow up is required. So 16 and 18 we have to directly mark in the SBA that if single best answer in the answers they are asking the question that HPV 16 or 18 is detected, so these patients should be referred directly for colposcopy. We have to collect the liquid based cytology, or in the same sample they will do the cytology, that simultaneously they will do. But all these patients who have a HPV 16 or 18 should be referred directly for colposcopy. Now, HPV vaccination. So there are some vaccines, quadrivalent HPV vaccine that protect against HPV type 16 and 18, high risk for cervical cancer, and 6L11, which causes the genital wart. Vaccination ideally occur before first sexual activity. This is very important point. And currently a 9-valent HPV vaccine, Gardasil 9, is administered through the National Immunization Program to both male and female at age 12 and 13 years. This is very important point. And they have also seen the maximal reduction of approximately 90% for HPV 6, 11, 16 and 18 infection, 90% for the genital warts, 45% for low grade cytological cervical abnormality, and 85% for high grade. So women who have been immunized still require cervical screening because the vaccine does not prevent all HPV types that cause cervical cancer. Thank you very much. This chapter, we have finished this chapter, cervical screening.